Okay, fantastic. Thank you very much for joining us today. It's my pleasure to welcome you all here to this symposium that's sponsored by Medtronic and CathWorks. My name's Rashra Alami. I'm from Imperial College London. And today we're going to talk about FFRangio and the CathWorks technology, where we are now globally and also where we are in Europe. And importantly, a lot has changed since our last symposium last year, and we'll be talking a lot about those updates. So here are my conflicts. So I'm joined today by a fantastic faculty. My co-chair is Ran Konowski, who will moderate your questions. So please feel free to put your questions in on the chat, or it's a small room and we're all friends. So please come up to the microphones and ask your questions. We'll be hearing presentations from Stefan Fournier, from Benjamin Honton, from Thomas Keeble, and from Hitosho Matsuo. And we'll obviously have lots of time for discussion and all of your questions. Our objectives today are to explore the practical application of FFRangio in routine practice. We're going to learn from centres who've had short-term experience in these last few months and those who've been using it for some years now and can tell us what's happened over the years that they've used it and how they've moved on to using FFRangio in their routine practice. And we will also get some updates on the clinical outcome data. Now, it's important to remember that the FFRangio journey has been going on since 2013, and you can see that since 2013 there has been a rollout of FFRangio globally, but also of course all of the relevant regulatory requirements, and importantly a very large global RCT which has now completed recruitment, and we will expect to have the results shortly, and we will see if FFRangio proves to have a real benefit in terms of clinical outcomes for our patients. Now, FFRangio is available in 500 cath labs in the United States and is growing, is used routinely in labs out there in the United States. And importantly, Japan has been leading the way with FFRangio, and you can see that it's available in over 250 cath labs, and Dr. Matsuo will tell us much about that, I'm sure. But I guess what's interesting to tell you compared to last year is we now have a real impact within Europe, and we've seen FFRangio being rolled out in cath labs across Europe in these last few months, particularly and importantly in this last year since our last PCR presentation. And that global launch is continuing. There are lots more geographies that will be reporting their FFR outcomes in time, but importantly, you will see and hear case presentations, etc., from cath labs across the world showing you the technology being used. It's been used now in over 100,000 patients globally, and you can see the kind of sharp increase in this last year or two, and we'll see if it continues to grow as we get more and more of the outcome data. I've got a photo of the launch of FFRangio in the UK. That was actually the first case that was done. Just after that first case, everyone's smiling. It all went very well, particularly Alex, who's sitting there on the front row, and he's smiling despite his jet lag. So we will move on to our session, and it's my absolute pleasure to introduce our first speaker, who's Benjamin Honton, who will talk to us about the early experience from France.
Thank you so much, Rasha, for this kind introduction. Dear friends and colleagues, it's my pleasure to share with you what is new in our cath lab since January. And let me introduce by a case. So it's a case of an 80-year-old man is suffering from restless chest pain, and he underwent a CT scan who suspect a 3-vessel coronary artery disease. And so far, he was referred to the cath lab, and you can appreciate the left network. So there is infiltration on all the networks with a mid stenosis on the proximal circumflex that you can show on the spider. But there is also an important infiltration on all the LAD, which is a long LAD, and on the mid part, we can assume that at least an intermediate stenosis, and with a severe stenosis on this diagonal. However, when we inject the right coronary artery, we found the solution, and this critical lesion on mid LAD with also a diffuse disease on the distality in this old man. And so far, he underwent by my colleagues an angioplasty, and we thought that the story was over. However, 3 months later, we see him in consultation. He was, of course, significantly improved from his chest pain. However, there is persistent angina, which is considered as disabling by the patient. So we came back to know if we missed something. And so far, we use the CathWorks angio-guided FFR, and for those who are not used to this software, you can see that it's very interactive, and you have to select 3 angiograms of interest with 30 degrees angles difference, and you can see that it's very easy to use. You put and you pull your 3 angiogram that you selected for the analysis. And after you go, you have a drag marker where you located what you suspect, what is your targeting suspicion. The software, you can see there, give the optimal part that it thinks, but you can also place it by yourself. And so far, we want to analyze this mid-LAD lesion. The second step is that you know that the algorithm is taking in account the collaterals. And so far you have this first diagonal, which was born very nearly after the distal left main. And so far you can manually go to selected all the collateral that you suspect to be involved in the disease. After calculating results, you can see this kind of nicely results. And there is no doubt on this LAD, you have a significant loss of charge at the mid part of the LAD, who confirm that this lesion was intermediate in QCA was significantly relevant on the myocardial. And we go also to analyze our post-PCI right coronary artery, and you can see nicely that at the level of the stent, you have a significant improvement of the FFR, and you have a significant lesion on the distal of the right coronary artery with a 0.73 on distality, which was respected in this patient. And so far, my colleagues go for angioplasty of the LAD. I don't want to ask about the strategy. He used a 2-stent strategy because he considered that this diagonal was important. And we can assess in the same fashion the post-PCI results immediately in your cath lab. And you have this feedback automatically in few seconds. And we know after that we done a great job because we have a 0.85 FFR at the level of the angioplasty. So nice. What do you think? However, I'm not a seller. I'm not here to sell you CathWorks or FFRangio. I am a physician. And so far, we have to stay critique. And so we conduct a little survey since January that we have the angio-guided FFR because we were 14 practitioners at Clinique Pasteur to be trained. And so far, I made an internal survey with 5 easy questions, 1 to 5. And the first was integration, the usability, the clinical confidence that you can have from this software and this FFR angio-guided, the impact on your decision, and the overall satisfaction of the system. And you can appreciate that in this survey, we have a high rate of confidence about the technology, high rate of confidence on the results. But which was interesting, and I think it's important for the rest of the session, the lowest rate, which was high, was on the clinical confidence. So the need to prove in a scientific view that the tool that you use is reliable. And I'd like also to prove by myself. So, of course, the 10 first, we compare it to direct FFR wires buyer, and you can see that there is a very, very strong correlation between what we measure on FFR wired and what we measure on angio-guided. And only 10 patients for a blunt Handman test, but you can see that there is a strong correlation. So if I have to conclude, the first feedback at Clinique Pasteur in January is highly positive. Highly positive because it's easy to use. It's very intuitive. The software is very easy to practice. And it gives a level of confidence which is high. We can moderate, of course, because the level of science needs to be improved, but I know that it will be improved, and there is data in this session, and we are all waiting for the oral trial. Of course, there is a cost consideration to take into account, especially in France, but I can tell you that it's a promising technology. Thank you so much.
Thank you very much for that excellent presentation. If you come and join us on the panel, our plan is to go through the presentations and then we'll have a long discussion, all of us in the room. So it's my pleasure to introduce Tom Keeble, who was the second lab in the UK to have FFRangio, and he's going to tell us about that UK experience.
Well, thanks very much, Rasha, and thank you, CathWorks, for inviting me to give the UK perspective. My conflicts of interest. So as Rash has already highlighted, her centre has it, my centre has it, and Musgrove Hill has it down in the southwest. What are the objectives that I'm going to talk through in the next 5 minutes? Well, the first thing is about how to get fantastic angiograms, and that's really important because many of us get lazy and many of us don't focus on the angiogram as much as we should. Number two, I'm going to talk about serial lesions, and I think we've learned loads about serial lesions in the last 6 months. And finally, what is the learning curve in our centre? And our centre has a very similar experience to the last speaker, around 50 patients, 75 lesions, very similar. So the first thing to say is that if you're going to rely upon angio-derived physiology, your angiogram has to be really good. So guide catheter is always better. 6 French is generally better. You have to have good engagement. You have to have no panning. And we've learned to take our angiograms in a very different set of views. So I always used to go apicranial, apicaudal, but I don't now. I now go areocranial, eleocranial, areocaudal, so that you've got the spatial resolution to allow you to do your quick analysis. And you may wish to vary that slightly, but I now take my angiograms better and in slightly different views. Let me give an example now how I think that serial lesions can be assessed using this technology. And I think, let's not forget, pressure-based systems, so pressure wire with serial lesions, doesn't work. We always stent the wrong bit. We always get disappointed if we do it again. And we know that that's a technical problem with pressure-based assessments. Sorry, let me go back. So 67-year-old lady, a very standard type of patient we would have in our centre. Risk factors, stable angina, good LV. And she's got this horrid-looking right coronary artery, heavily calcified, incredibly unpleasant. 2 discrete stenoses, 1 proximal, 1 mid, heavily calcified with some distal disease too. And so again, would you really want to pass a pressure wire down this to understand the serial nature of these 2 stenosis? No way, and you probably wouldn't get one down either. However, of course, with CathWorks, with good angiographic pictures, it doesn't care. So you can take your angiograms, as long as you've got good angiograms, good opacifications in the views that it wants. You get a distal FFR of 0.58, as you would expect. And what I really like about this is the ability to determine what is causing those flow and pressure drops. And you can see on this next slide, there are essentially 2 proximal steps, as you would expect from the angiographic findings, and there is a distal step. But because of the calcification, we elected not to treat the distal step and just do the first 2 proximal ones, which you're well within your rights to do. The second thing I really like about it, and we're going to hear a little bit about it in a later talk, is that it gives you essentially a QCA type sizing tool. So this tells me that this is a 3mm vessel at the top, but we know that by timesing that by 1.25, that gives us the size that we should probably implant. And so we're going to be putting in here a sort of 375 type stent. Now, there's, I think, heterogeneity around image use. Some people use lots, some people use almost none. But I can't help but think that this tool for those non-imaging doctors is going to be an extremely helpful way of supporting a diameter suggestion. So we IVUSed it anyway, and we get exactly the same number. We get about 3.5, so a 3.5 stent. So I actually put a 4.0 stent in distally after orbital atherectomy and a 3.5 stent in at the top, and I ignore the distal sort of fairly diffuse disease. But as we've heard before, the beautiful thing about this technology is I can see exactly what I've done with really no extra effort or images, and it takes, as we know, a couple of minutes to give us the answer. And so I get a distal FFRangio of 0.83, not perfect, but I think you'll agree probably good enough for the investment that we've got with regards to that distal disease. And you can see there is just a very minor step distally, which I've chosen from the get-go because of its a complex nature of the disease to leave that alone. We've done some little internal projects too, like my colleague. So experts who taught us do their analysis in 2 minutes and 39 seconds, which I think we would all agree is pretty quick. Novices, and what I've chosen novices, that's our fellows who have just been trained how to do it, but literally it's their first 25 cases. They take 4 minutes, 30 seconds. And of course, they're going to take slightly longer than someone who's been doing this for many, many months or years. And you can see the correlations between the expert and the novice are essentially identical with very, very good correlations. And of course, the cut point areas are equally impressive. So I'm very confident that the number it gives you, it doesn't matter if you're an expert or a novice, I'm very comfortable that my lab can give me the right answer very quickly. So my conclusions in this short period of evaluation over a 4-month period with around, as I say, 75 lesions, is that it appears to have excellent accuracy because like the other group, we have been doing some FFR at the same time. The cath lab efficiency can be extremely good too. Serial lesions, I think it's genuinely game-changing because of the challenges of pressure wire and pressure drop. I think you can use it to estimate diameter if you're not in intravascular imaging. I think the post-PCI assessment really is incredibly helpful to know exactly what you've got at the end. And I didn't have time to talk about, I think non-culprit assessment in ACS patients is potentially a really useful future way to understand that patient and what you're going to do in the future. Thank you.
Thank you very much, Tom. Now it's my pleasure to introduce Stéphane Fournier, who really has some of the longest and most long-standing experience in Europe using this technology. So we'd really like to hear about how you've made it the standard of care, Stéphane.
Dear colleagues, dear friends, thank you very much for the kind invitation. It's actually my pleasure to share with you my reflections on how FFRangio could become the standard of care. And I will share with you my journey with FFRangio from discovering it as a fellow, I think it was like 8 years ago, to implementing it in a tertiary university hospital in Lausanne, Switzerland. But before, we need to think about this question. Do we need a new standard of care? Because FFR, wire-based FFR, is extremely well validated and it's almost everywhere available. But there is a risk due to the procedure. There is a complication risk in this kind of vessel. We just saw in the previous presentation. There is a time because you need to manipulate your wire, but you also need to ask the nurse to bring you the material. You need to change for a guiding. You need to open your software. There is a cost. Obviously, you have to pay the wire. You have to pay the drug, adenosine, papaverine, or whatever you want. There are sometimes also some complexities. You can have a nice value, you're proud of you pull back and you realize that you had a drift and you have to start everything again. And we have to acknowledge also that this wire is somewhat difficult to manipulate. So yes, I think a new standard of care could be of interest. But what does it take to become the new standard of care? And I think there are 5 rules to become this new standard of care. First, we need a strong performance compared to the invasive gold standard, it's obvious. But there are the results we see in the literature and also the results that we see by ourselves. And I think we need a strong performance that we see ourselves in our own patients. But we need also a strong performance compared to the competitors, because you know that there are different solutions on the market. We need also a solution that is easy to implement with a fast and intuitive learning curve. And finally, we need also a solution backed by clinical endpoints on a proven cost efficiency. And it will be the 5 topics I will discuss with you. First, the strong performance compared to the invasive gold standard. These are the results of the main trials comparing FFRangio versus invasive FFR. I was involved in the second one, the fast FFR trial. But as you can see, there is a very nice consistency between the different trials. The accuracy is always the same, 92 to 93. It's efficient, the sensitivity is excellent, the area under the curve also. But, you know, before you implement it in your cath lab, you want to see by yourself. And it's what we decided to do in Lausanne. So we performed different studies with Dr. Skelidis, who is also here in the room. We decided in our patients to perform a comparison of FFR wire versus angiography FFR. And actually, we obtained exactly the same results. We had even an accuracy of 97%, and we were able to confirm the results here in a different setting because we were dealing with non-STEMI patients. Good to know it's also working in acute coronary syndrome setting. But then, if you're the head of the cath lab, there are different products available, and you have to choose the one which fits better with what you need. And we decided also to compare in our patients two products, and actually we performed a head-to-head comparison of QFR versus FFRangio. Same lesions, same vessels, same operators doing the interpretation of the images. So here you have one of these patients, stenosis in the middle AD. On the left side, FFRangio, we had a value of 77. On the right side, QFR, exactly the same value. These are our results. The correlation was actually a little bit better with FFRangio, 0.76 as compared to QFR, with also less misclassifications. And in terms of diagnostic parameters, also you can appreciate that the accuracy was better for FFRangio, 94 versus 82, and it was due to the sensitivity, which was better for FFRangio. Okay, it's nice, it's working in different settings, in acute coronary syndrome. Apparently it's extremely good as compared to other solutions, but you need also a solution that is easy to implement with a fast and intuitive learning curve. And this is something also we decided to investigate. So here we created a group of paramedics, nurses, fellow, and they all receive a basic teaching with QFR and with FFRangio. And we asked them to analyze 55 cases. And we measured the performance and the time to have the results. This is what we observed. So here we have the case number 0, the case number 55. And here, this is the absolute difference between FFRangio, or QFR, and the invasive results. As you can see, it's a flat line. What does it mean? It means that from the beginning, your performance is excellent. We can trust the value of a fellow, of a nurse, who is doing the first case. And this is extremely good to know. This is true for both software. But then, and it's exactly what Thomas shared with us, the time. The time here on the left, this is the time at your first interpretation. It's quite long. But then, as you can see, the more experience you have, the more faster you become. This is good to know. From the beginning, we can trust your value, but with experience, you are always faster. But we need also a solution backed by clinical endpoints on proven cost efficiency. We will probably discuss it today, the ALROS trial, and I'm proud that we included a lot of patients in this trial in Lausanne. So 2,000 patients were included. They were randomized either to FFRangio guided treatment or to pressure wire guided treatment. Based on the value, patients were treated either by PCI or they had a medical treatment. And the endpoint here, this is after 1 year, there will be a clinical assessment, non-inferiority in terms of MACE. Thank you very much for your attention.
Thank you very much, Stefan. And now we'll hear from Hitoshi Matsuo, who will talk to us about the evidence base. And I think we've heard from many of the talks that we're waiting for more and more evidence. So please let us know where we are now and what we're waiting for.
So, hello everyone. It's my great pleasure to be here to present about the evidence of the FFRangio. Before entering the evidence, I would like to show the situation of Japan, how FFRangio spread. From the 2019, we started to use the FFRangio as shown here, and according to the time passed, this FFRangio system spread all over Japan. Now it's 243 institutions can use the FFRangio now. And Stefan already showed this slide. But when we look at the prospective comparison between the FFRangio and wire-based FFR, we can see a very good diagnostic accuracy, like more than 90%, as shown like this. And the correlation between the invasive FFR and FFRangio is very excellent. And, FFRangio diagnostic accuracy is much better than the non-hyperemic pressure ratio. And from the literature, published literature, you can see the diagnostic accuracy of the FFRangio is better than looks like better than the MEDIS QFR. And how about the outcome trials? This is the data from the 7 centers in Japan and Rabi Medical Center in Israel. We enrolled 1,433 patients, 35 patients, who are mainly determined revascularized or deferral on the basis of the FFRangio value. We can find that deferral of FFRangio is fine, 1.6% per 1 year. And on the other hand, revascularized populations, 6.8% per year. This number is very similar to the invasive FFR outcome data as shown like this. You can see deferred patient is 2.3% in the invasive FFR data, and the deferred patient outcome in this current data is 1.2%. So deferral based on FFR may be very clear, very safe. And when we, for the patient, managed to in accordance with FFRangio guidance, cumulative rate of cardiovascular death, MI, and unplanned revascularization was 3.6%. On the other hand, for patients managed in accordance with FFRangio guidance, this rate was increased to 8.7%, nearly 2.5 times higher. So this data suggests that use of the FFRangio value, we should follow the number of the FFRangio value like this. This morning, Dr. Tanigaki from Gifford Center presented at the late-breaking clinical trial in this meeting about the Provision trial. So let me introduce some of this. So Provision trial is a multi-center prospective randomized trial. 401 patients were enrolled, and 203 were allocated to the FFRangio guided strategy arm, and 198 patients were allocated to the invasive FFR guided strategy. Primary endpoint of this study is non-inferiority in the vascularization rate of FFRangio compared to the invasive FFR. As the secondary endpoint, we checked the MACE at 1 year and the medical costs associated with the treatment. And this is a background of the patient. As you can see, there are no statistical difference between the FFRangio arm and the invasive FFR arm. Note that about 80% of the patient is a one-vessel disease. And you can see LAD is 60% in each arms. This is a value of FFRangio and the invasive FFR value. You can see FFRangio shows a 0.79, and invasive FFR shows 0.80. It's not statistically significant. And as you can see, in the blue dot represents the revascularization group, and gray dots represents a deferred group. So many of almost all of the lesions are followed by the FFRangio value or invasive FFR value. value. So this is the primary endpoint. You can see if we use in the FFRangio arm, 41.4% were sent to the revascularization. On the other hand, invasive FFR, 7.9%. This difference is 3.5%, and statistically, FFRangio was not inferior, not higher than the one of invasive FFR guidance. How about the MACE? You can see no difference of MACE, even excluding peri-procedural MI, and all-cause death, myocardial infarction, spontaneous MI, and target vessel revascularization. No difference is observed. And how about the radiation exposure in the study? So radiation exposure is significantly lower in the FFRangio group, and the duration of measurement is a little bit longer in the FFRangio group. This is why this happened. I think the 80% of the patient is a single vessel disease. So if the number of the multi-vessel increases, maybe the difference may be converse. I think so. So the limitation of this study is designed to evaluate the non-inferiority of FFRangio compared to FFR with respect to revascularization rate. So the sample size was not enough to assess clinical outcomes such as MACE. Therefore, upcoming all-rise study, we have to wait for the final answer to whether we can. It's not in FFRangio. Decision making is not inferior to the pressure wire assessed strategy. So I will skip the all-right study. So all-right study is a prospective randomized trial comparing the FFRangio and the pressure wire guided treatment. This primary endpoint is the clinical outcome. So we would like to wait for that. So study site is 43 sites in US, and 2 sites in Israel, and 8 sites from Japan, and 6 sites in EU. So the take-home message is here. FFRangio has demonstrated excellent diagnostic performance compared to wire-based FFR. Real-world data have shown the strong prognostic value of FFRangio guided decision-making. The provision trial, the first prospective randomized trial comparing FFRangio guided and wire-based FFRangio guided decision-making, reported similar revascularization rate and comparable clinical outcomes. The upcoming all-right study is expected to further reinforce the evidence supporting the use of FFRangio. Thank you very much for your attention.
Thank you. Thank you very much. And now it's our discussion time. So please feel free to go up to the mics and also submit your questions. Rana, I know that you've got a number of questions there, but I'd like to ask your experience first, because you've really been using this technology for a long time. How did you start to make it the standard of care, and where do you most use it in your patients?
I think that over the last few years, it really became a standard of care in our practice, and actually we've been using wires only when we had to randomize, such as for the all-rise, the fast FFR, which was the pivotal trial for the FDA. So in our practice, it became truly the standard of care. I think that both the operators and technicians feel very comfortable in using it. The analysis time is short, much shorter than was just mentioned in the provision. Many people would say that we are biased because, I was a co-founder of this, but, we have multiple operators, and they do what they think is best for their practice and for the patient. So I think it's really becoming a very valuable tool. I can also tell you a small anecdote, which is a feedback from the old rides. Whenever we had to wait for the randomization, operators really were, expecting to have the FFRangio, and whenever they had the wires, they said, okay, now I have to do the wire. So it's a kind of reflection of the atmosphere in our lab. But again, remains to be seen. I was intrigued to see the early experience, the more extensive experience, and the operators such as Hitoshi who have been using it for years as well. So we have, I think, two questions or feedbacks. Maybe Dr. Matsuo can answer. One relates to the time of FFR angio versus wire-based FFR. Was it both online measurements, or one of the techniques were offline? This is one question, and the second one relates to the cost model of the FFRangio versus the wire-based FFR, at least in Japan.
Yeah. At first, Japan has some limitation for the use of the FFR in that we are not allowed to use this angiography in the diagnostic stage. I mean, ad hoc situations, we can't use the FFRangio. Therefore, usually many of the hospital doesn't have the systems online. I mean, offline system is common in Japan. And so it is a little bit difficult to calculate the difference of the time spending. So many of the hospital are angiography first, and after that, maybe technicians measure the FFRangio. So it's a little bit different situation of maybe in Israel, I think so.
And the cost model is similar for wire-based versus FFRangio? Can you comment on that?
What's the
cost?
Cost of the, yeah. So we didn't finish the final result of the cost evaluation, and we have to check that. But at this moment, we think that at least FFRangio is much, probably FFRangio is cheaper than the wire-based FFR, right?
Can I just comment the 2 points? The time to have the value using FFRangio. I think there is something important to realize. If you have a one vessel disease, okay, maybe if you are fast, if you already have a guiding in position, wire-based FFR can be fast, no discussion about it. But you saw in the case of Benjamin that with FFRangio, at the same time, you have all the vessels you want. So you can have the LED on the circ at the same time. And you do one reconstruction, you pay attention with the acquisition of the angio, but in a few clicks, you have all the branches you want. And you are faster than invasive FFR, where you have to go into every branch. This is important. For the cost, in Switzerland, the price we pay to have a card to perform analysis with FFRangio is quite comparable as the cost of invasive FFR, but there are some cases, if you think about it, you earn money because let's take into account STEMI patients. You open the culprit in the middle of the night and there is another stenosis. You decide to go to bed again, and on the following day you have the choice. You can just analyze the stenosis on the non-culprit with FFRangio, or you can bring the patient to the cathlab, but you have to pay everything again. You have to open a new catheter, you have to inject. It takes time because you need 45 minutes in the cathlab to have this patient. So you have to take everything into account before deciding which is cheaper.
So more questions. One relates to the use of nitrates for the diagnostic FFRangio calculation. Second relates to the post PCI tool, whether it can be used on a regular basis. Anybody wants to comment on that?
Nitrate use, you mean? Nitrate? Yes, we in our routine practice, we use the nitrate before using the FFR angioanalysis. So angiography should be taken with the maximally vasodilated, right?
And the use of post-PCI tool?
Yeah, you've seen it's very useful. I spring up on the nitrates. Thomas said that you need a good angio, and it's perfectly true. You need to have a good injection to have the best results. And for the purpose of the post-stenting, it's quite easy to use. And you see also in the case that we have presented, you have the results, of course, at the level of the stenting, but you have all the artery, and in both of the cases, you can see that the FFR at the end of this right coronary, in both of cases, is not perfect, and we assume that. And so I think it's a very valuable tool for assessment of post-PCI results. Absolutely.
I completely agree.
I was just going to say the other thing is that it can be quite fast for the post-PCI because you only have to drop in one extra angiogram and you've already got the other two there. So I think it's an extremely effective way to ensure that you've got the quality for your patient, which we know is a surrogate of outcomes.
Another question relates to the use of this tool in a scenario when there is concomitant lesion or intermediate grade lesion and microvascular dysfunction. Is it a yes or questionable?
Well, tandem stenosis, diffuse disease, in my experience, it doesn't affect. So I trust the value. It is something we observed in our practice. I was thinking about microcirculation impairment. Well, the problem is, how do you know that there is a microvascular disease? Well, for the time being, if you want to know it, well, you need a pressure wire. So I think when I want to assess the microcirculation, and we have a dedicated NOCA program in our institution, we use the pressure wire. And well, I know whether the patient has a CMD or not. And in this case, obviously, I'm not using FFRangio. So the future is probably this kind of software to assess the microcirculation. There are some preliminary data. There are a lot of development ongoing. And this is probably one of the future, I think, this technology. If you can see just based on the angio, if the patient has a CMD, it will change. But for the time being, I don't know if the value of FFRangio is correct if there is a CMD, because I'm not using it in this context.
Yeah, I can just make the comment that you can use it in CMD scenario and it would be reliable. So the system is really compatible with both CMD and no CMD cases.
Okay, so we have another question, and maybe I can bring it to Dr. Matsuo about the intra and inter-observer variability of this technology. What's the reproducibility?
Yeah, we checked at the first of our introduction of the FFR angio, and fairly good correlation between, and I can't give you the number now, but the intra and inter observer variability is, I think, acceptable, right?
Great. And then we have some questions around specific scenarios. Tom, maybe you could take this one. So we often get told that physiology is less reliable in the acute coronary syndrome setting. Are you happy to use the angio-based tool in that setting?
I think I'm clearly happy in the non-culprit. I think we would often use conventional FFR in the non-culprit, and I think as long as you're happy that you haven't got a couple of culprits and you don't know what the culprit is, but I think the culprit's very clear. I'm very comfortable to use this in the non-culprit vessel, and I think it is one of the major reasons why we probably should be considering using this technology, because as we've heard, very quick, very easy, and you've got all the data and you don't have to take the patient back to the lab.
I have a hypothetical question to you, Rasha. Assuming the all-wise results would be in accordance to the provision data that were just presented by Dr. Matsu, how would it impact the guidelines in terms of the physiologic assessment?
Yes, I mean, I think if we have non-inferiority, much as was the case with resting indices with IFR, then I think you can start to talk about, class 1A indications on the basis that it's the evidence is already clear that a use of a physiological assessment improves outcomes in patients. And if you can then show that the next form of physiological assessment is non-inferior to those that have been the gold standard, then I think it becomes easier. But we'll see. I mean, the guidelines are always unpredictable. So we're pretty much at the close of the session, but I'm just going to ask one final question to Stefan. There's a question about pattern of disease. Do you ever use this technology to consider pattern of disease? Do you think that's coming? Where do you think it sits with diffuse versus focal lesions?
Diffuse disease, you mean? Or? Well, the problem with diffuse disease is when the vessel in the distality is extremely small. It's sometimes quite difficult with this kind of technology, to have the control of the vessel extremely accurate. So if you have a very small disease in a diabetic patient, and from the middle AD to the end, it's extremely small, it can be challenging. And in this case, sometimes I use the invasive FFR. But if you are dealing with a vessel which appears to be diffuse, but you have the end of the vessel is 2 millimeters, I'm quite confident to use FFRangio, and this is also something we observed in our clinic.
Fantastic. Thank you. So thank you very much for a very interactive session. Thank you very much to my co-chair and to all the panelists. And we'll stick around for some questions in case there are any further, but thank you very much.